Hey there, and welcome back to the deep dive. You know that feeling when you're faced with just this mountain of information,
Yeah.
especially on something as critical as healthcare, and you just don't know where to even begin? It's kind of like standing at the ocean's edge, needing a specific type of shell, but then realizing, wow, the entire beach is covered in billions of them.
Yeah.
And, new ones are washing up every second. The sheer volume can be completely paralyzing.
Oh, it's an absolutely relentless challenge, really, for anyone involved in providing patient care or, say, developing health policy. Trying to sift through every single individual study to make informed decisions is, well, it's quite simply impossible. The pace of new research is truly staggering.
Absolutely. So our mission today really is to cut through that information tsunami. We're exploring a remarkably intelligent solution, a kind of meta strategy that helps experts make sense of this overwhelming evidence. We're talking about the methodology behind systematic reviews of systematic reviews, or as they're often called, overviews.
Mm.
And our guide for this deep dive is a really fascinating research article, Methodology in Conducting a Systematic Review of Systematic Reviews of Healthcare Interventions. This is basically your shortcut to understanding how the best minds are building layers of knowledge to find clarity in all that chaos.
That's a great way to put it, layers of knowledge.
So let's really set the scene here with the scale of the problem. Our source tells us the healthcare literature isn't just large, it contains literally hundreds of thousands of studies. And it's expanding by tens of thousands every single year. It's not like a static library, it's this ever-growing, dynamic universe of data that honestly no single human could ever hope to fully grasp.
Indeed. And researchers, well, they quickly understood this wasn't sustainable for evidence-based practice. It just wasn't working. This realization spurred the development of individual systematic reviews. Think of these as the first major filter, rigorous analyses that appraise, summarize, and bring together all the existing studies on a specific intervention in one coherent place. Organizations like NIE in the UK, the AHRQ program in the USA, the Joanna Briggs Institute, and the International Campbell and Cochrane collaborations, they all emerged to champion this work. Cochrane, for instance, became a real powerhouse, publishing over, 4,200 systematic reviews by the end of 2010 alone.
Right. So individual systematic reviews were the answer initially. They were like the beacons guiding us through the fog of primary research.
Yeah.
But then a new problem emerged. Almost an ironic twist, isn't it? Our source explains that decision makers who were once overwhelmed by the number of individual studies have now, quote, become faced by a plethora of reviews. So, in essence, we solved one problem, only to create a higher level version of the exact same problem. Now we're overwhelmed by the reviews themselves.
Precisely. And this is where the landscape got, well, complicated. These individual reviews, you see, they can vary quite significantly in their quality, their scope, even their conclusions sometimes. It's actually quite common to find multiple systematic reviews addressing the same clinical question, maybe even with conflicting results.
Really?
Yeah.
Conflicting?
Oh, yes. For example, a search looking at nurse and midwife-led interventions in Ireland identified over 30 separate systematic reviews. Now, imagine you're a busy clinician trying to make a critical decision. How do you know which review to trust? How do you synthesize their, often divergent findings efficiently? The very solution became part of a new challenge.
Okay, so if even the reviews are becoming overwhelming, what's the next logical step? How do we find that clear, actionable information? This is where the systematic review of reviews or an overview comes in, right? It's the meta-level solution, the next layer.
Exactly. This is the logical evolution in evidence synthesis. Overviews are designed to address that plethora of reviews problem directly. They let us rigorously compare and contrast the findings of separate individual systematic reviews. They provide a high-level summary of evidence from multiple systematic reviews, pulling insights together. This might mean combining findings across different interventions for a condition, or different outcomes, various patient populations, or even summarizing adverse effects from a much broader perspective. The Cochrane collaboration itself recognized this critical need and formally introduced this new type of review back in 2009. It really highlighted its growing importance in filtering research.
Okay, so if you're going to conduct one of these overviews, summarizing all the best summaries, essentially, where do you even start? Sounds incredibly complex, almost like you're not just reading books, but reading summaries of entire libraries.
It can be complex, yes. But the starting point, like with any rigorous research, is absolute clarity. The precise objective, the reasons for conducting this specific systematic review of reviews, they must be made explicit right from the outset. This initial clarity is paramount because it directly dictates every single methodological choice you'll make down the line. Without a clear purpose, the whole undertaking can quickly become, well, unfocused and pretty unwieldy.
And our source mentioned a helpful tool for scoping this out, a structured way to define the boundaries of your review of reviews.
Yes, the PCS structure. It stands for Participants, Interventions, Comparators, Outcomes, and Study Design. It's highly recommended for this. It's a standard framework, really, that helps you delineate exactly what your review of reviews will cover. For example, it helps clarify, are you comparing reviews on the exact same treatment? Or maybe a specific intervention for a particular patient group, or even a broad range of interventions for people with a certain condition. This early, meticulous planning is much like preparing for a standard systematic review of individual studies, but with specific considerations for how you handle systematic reviews themselves as your sort of units of analysis.
Got it. Okay, so we've established the why and the basic framework. Now let's turn to the how. The nuts and bolts of actually building one of these overviews. Our article breaks it down into several key aspects, right? Detailing the practical steps and challenges.
That's right. It gets quite practical.
So first up, finding the right literature. This is fundamental, obviously, but it also sounds like a huge hurdle because now we're looking for reviews, not individual studies. It sounds like a very specific kind of fishing expedition. How do you develop that search strategy?
It absolutely is a specific kind of search. The methods are similar to individual systematic reviews, but with subtle yet critical differences. For example, while a typical systematic review might take, say, 6 to 18 months to complete, an overview could potentially be faster.
Faster. How so?
Because the search can be much more targeted. You're specifically looking for systematic reviews rather than having to sift through countless individual primary studies. It narrows the field. So instead of searching broadly across many decades, which you often need for individual studies, you can frequently limit your searches to specialized databases. Databases designed specifically to catalog systematic reviews. Resources like the Cochrane Database of Systematic Reviews or the Database of Abstracts of Reviews of Effects, DARE, they're perfect for this. DARE, for instance, gives you structured abstracts of reviews on healthcare interventions, plus critical appraisals. Very useful. And searching from, say, the early 1990s onwards is usually sufficient. Systematic reviews were pretty rare before then.
Right. Okay. But I imagine finding all the relevant reviews is still tough. And then there's the language issue. Is it ever okay to just stick to English to make it, manageable?
That's a crucial point. Generally, language restrictions are not recommended. They can inadvertently introduce significant bias into your findings by excluding relevant, maybe high-quality research published in other languages. This could lead to an incomplete or, frankly, skewed picture of the evidence.
Okay.
However, practical constraints, lack of access to translation services, funding issues, might, in some unavoidable cases, make it necessary. But if that happens, this limitation must be explicitly acknowledged and discussed when you report the review. It directly impacts how widely your findings apply.
Makes sense. And the actual search terms, how do you craft those? You need to be precise, but not miss things.
Exactly. They need to be very clearly described. Focused enough to accurately capture relevant data, but also broad enough not to miss anything crucial. Over time, specialized search strategies have actually been developed specifically to identify systematic reviews. You can then combine these with terms for your particular healthcare topic. There's even an initiative called Press Peer Review of Electronic Search Strategies, which helps ensure search strategies are thorough and accurate. Experts review them.
Oh, interesting. Peer review for the search itself.
Yes. And beyond electronic databases, to really minimize the risk of missing relevant reviews, a manual search of key journals is important. Also, checking the reference list of reviews you've already identified is highly recommended. You can also contact experts in the field. They might know about unpublished or ongoing reviews. And another tactic is checking articles that cite individual studies you know are relevant that might uncover reviews missed by databases.
Wow, okay. So it's quite a detective work process even before you start reading the reviews. Okay. So once all that meticulous searching is done, you're going to have this probably massive list of potential reviews. How do you decide which ones actually makes a cut? Where ones to include in your overview?
It really is a filtering process. The first step is to establish a dedicated review team. Ideally, this team includes at least one person with methodological expertise, someone who really knows systematic reviews inside out, and another person with deep topic-specific expertise.
Right, the how and the what.
Exactly. This combination ensures both the rigor of the process and the accurate interpretation of the content. Crucially, this team then develops clear inclusion and exclusion criteria before starting the selection. That's vital for objectivity. For example, your criteria might specify only reviews of randomized controlled trials, or maybe those focused on a particular patient group, like women having their first baby, or perhaps reviews assessing a specific type of pain relief. You define it upfront. Then the selection process mirrors what you do for individual reviews. You assess the titles and abstracts you found for relevance, remove duplicates, then you get the full text copies of the promising ones. And finally, this is really critical for minimizing bias. At least 2 independent members of the review team assess these full text reviews. They check them for both relevance and quality against your predefined criteria.
2 independent people.
Yes, that dual independent assessment ensures robustness. And it provides a chance for discussion if there are any uncertainties or disagreements between the reviewers.
This brings us to a really crucial point. The quality of those reviews you're including. I mean, if you're building a summary of summaries, those individual summaries absolutely have to be good, right? The whole structure depends on solid foundations.
Absolutely. Couldn't agree more. The strength and the reliability of your overview's final conclusions hinge directly on the quality of the individual reviews you've included. And published reviews can vary widely in their quality and scope. It's a real mix out there. So when assessing quality, you need to avoid being swayed by, external factors like the author's reputation or how prestigious the journal is. The focus must strictly be on the conduct of the review itself. How is it actually done? This is why initiatives like PRISMA are so important. PRISMA is basically a checklist to help researchers report all the essential aspects of their review. It makes it easier for others, like you doing an overview, to understand and appraise the review's quality.
Okay, so PRISMA helps with reporting. But how do you assess the quality itself?
Well, what's particularly interesting here is that our source highlights the AmStar tool, a measurement tool to assess systematic reviews. And it's described as the only validated tool specifically for assessing the methodological quality of systematic reviews.
The only validated one.
Wow. Yes. It gets right to the heart of what makes a review trustworthy. AmStar looks for things like, was the research question and inclusion criteria established right up front? Was the literature search truly comprehensive? Did they look in at least 2 databases, consult experts? Did they assess the quality of the studies within their review? And importantly, how did that assessment influence their conclusions? It also checks if they assessed homogeneity. Are the studies similar enough to combine? And publication bias, the tendency for positive results to get published more easily. These are all absolutely critical checks for protecting against flawed conclusions.
Right. So AmStar gives you a structured way to judge the review's rigor.
Precisely. For example, the authors of our source paper mentioned their own criteria included assessing the extent of searching done by the original reviews, were the databases, years, restrictions clearly described. They also looked for detailed descriptions of how reviews were selected and the inclusion criteria used. They examined how things like publication bias, maybe using a funnel plot analysis, and heterogeneity were addressed. They even looked at the comparability of included reviews. For instance, they made sure to separate results for women who were symptomatic versus asymptomatic for preterm birth, when relevant, to ensure that direct comparisons were truly appropriate. This level of scrutiny ensures that only robust, unbiased evidence forms the basis of the final overview.
Okay, so after all that meticulous work, the searching, the filtering, the quality assessment, how do you actually present these incredibly complex, multi-layered findings? How to make it clear and useful and, actionable for a clinician or a policymaker? It's about distilling all that dense information.
Yeah, the presentation is key. It must clearly provide the major conclusions of the overview. It also needs to show the specific evidence on which those conclusions are based, and crucially, include a transparent assessment of the quality or certainty of that evidence. This often uses approaches like grading of recommendations, assessment, development, and evaluation.
Grade, right. I've heard of that.
It's a widely used system to assess the certainty of evidence. Basically, how confident can we be in the findings? Which is vital for making strong recommendations. And it's really important to be highly specific about the primary outcome of interest for your overview. So if your overview is about preterm birth, for example, you'd only extract results directly related to that outcome, even if the original reviews covered lots of other neonatal outcomes. This helps focus the message and prevents information overload for the person reading it.
And given the complexity, I imagine visual aids are pretty much essential here. Tables, figures.
Oh, absolutely, yes. Summary tables and figures are incredibly helpful. They present results in a structured, clear format that really enhances the textual commentary. Our source actually provides excellent examples. Table 1 illustrates how to summarize the scope of included reviews, and some of their quality aspects gives you an at-a-glance understanding of their foundations. While Table 2 shows how to present the summary results from each original review. For instance, the effectiveness of different tocolytic agents. Those are drugs used to suppress premature labor and preventing preterm birth, including their statistical significance and confidence intervals. And the PRISMA statement, even though it was initially designed for individual systematic reviews, also offers a very useful framework for transparently reporting these overviews.
Okay, so boiling it all down,
Yeah.
what does this mean for healthcare professionals, for researchers on the front lines, or those trying to advance science? Why should they care about this whole extra layer of review when they already have individual systematic reviews? What's the real practical impact?
That's a really important question about the real-world utility. One of the biggest problems for decision makers when they find multiple individual reviews on the same topic is the potential for inconsistency. Different reviews might reach different conclusions, right?
Right, which adds to the confusion.
Exactly. A systematic review of reviews directly addresses this critical issue. It can provide much-needed reassurance if conclusions across multiple high-quality reviews are consistent. Or, crucially, it can highlight and potentially clarify why they are not consistent, prompting further investigation, perhaps. It also allows for that robust assessment of individual review quality, bringing together the best available evidence from across the landscape of reviews into a single, definitive summary. Ultimately, what this sophisticated layering offers isn't just more information, but hopefully a reliable, fast-track filter to the most trustworthy insights in a field that's just drowning in data. And that is invaluable for informing clinical practice and guiding future research priorities.
Okay, that makes a lot of sense. It's about finding the signal in the noise. But we've talked about these layers of review, and here's where it gets really nuanced. The kind of meta-challenge, maybe. What happens when the reviews you're reviewing already contain their own meta-analyses? Can you just combine those numbers again? Like a meta-analysis?
Ah, yes, that's indeed the major challenge highlighted in our source. Creating a meta-analysis of included reviews, which are themselves meta-analyses. The significant risk here, the big pitfall, is that you could end up double counting data from the original individual primary studies.
Double counting. How?
Well, if the same primary study was included in, say, 2 or 3 of the systematic reviews you're summarizing, and you just pool the summary results from those reviews, that primary study's data gets counted multiple times in your final number. It's like thinking you have a huge army when you've really just counted the same 10 soldiers 2 or 3 times over. This artificially inflates the statistical power. It makes your result look much more precise than it actually is. And that leads to a misleadingly precise and therefore potentially incorrect estimate of the intervention's effect. It creates this false sense of certainty, which honestly can be far more dangerous than acknowledging uncertainty.
So you absolutely cannot just throw all the summary numbers together then,
Yeah.
even if they're already nicely summarized in the reviews you found. Sounds like you need to be incredibly careful not to overprocess the data and introduce these kinds of serious errors.
No, absolutely not. You have to resist that temptation. Overcoming this specific challenge would require what our source calls unpicking each of the included systematic reviews. This means going back into those reviews, identifying and extracting the results of the original individual studies they analyzed.
Going back to the primary data level.
Essentially, yes. Or at least to the results reported from the primary studies within each review. And then combining this primary study results in a new, distinct meta-analysis for your overview, making sure no single study is counted more than once. Now, this is a highly complex and very time-consuming task. Its value and feasibility really need careful consideration when you're planning the systematic review of reviews in the first place. It truly underscores the importance of having very clear, compelling reasons for undertaking such a deep dive and also understanding its potential limitations.
Wow, okay. So we've really gone on quite a journey here from that overwhelming sea of healthcare studies to this elegant, multi-layered solution to systematic reviews. It's truly a testament, isn't it, to how researchers are building these layers of knowledge and methodological rigor to try and make sense of staggering complexity. It's not just about more data, but finding better ways to process and actually understand it.
Exactly. That's the goal. The methods we've discussed today, drawing on the practical experiences outlined in our source paper, they're specifically designed to enhance evidence-based knowledge and ultimately to support well-informed clinical decision-making. For clinicians, for researchers, for policymakers, a well-conducted systematic review of reviews is often the ideal starting point for gaining comprehensive knowledge from research on a given topic. It offers that reliable shortcut, that filter to the most trusted evidence currently available.
Fantastic. That's a great summary. So as you, our listeners, navigate your own areas of interest and learning, whether it's in healthcare or maybe any other field that's just drowning in data these days, think about how even the most complex information can be distilled into actionable knowledge. Consider how one layer of research can build upon another, refining our understanding and bringing us closer to clarity, closer to robust answers. What overviews might you seek out in your own fields to help cut through that information noise and find those definitive summaries? Something to think about. Thanks for diving deep with us.